Alright, hi everyone, and welcome back to the journey. Today, as you can see, we're going to be talking about appendicitis. Now, with appendicitis, pretty much it is an inflammation of the appendix. Remember, anything with itis at the end, right? Itis means inflammation. So we know that inflammation is occurring somewhere, right? Where exactly? Appendix, in the appendix, all right? So the inflammation occurs in the appendix, right? And when the appendix becomes inflamed, you have the probability of it rupturing. And when it ruptures, right, it ruptures within a matter of hours or so, and it leads to peritonitis. If you want information about peritonitis, I have check out my other GI track lectures, and you will see information about peritonitis, especially in the diverticulitis disease. I go in a little bit more in depth about peritonitis, okay? So if you need any more information about peritonitis, you can also check out the diverticular disease video, all right? And it can ultimately lead to sepsis. And sepsis is pretty much infection all throughout your body that causes septic shock. From there, there's a lot of procedures that you have to go ahead and do. They check the lactate, fluid resuscitation, things like that, okay? So just think of, when you think of sepsis, it's bacteria or infection of the blood, right, that goes through the whole bloodstream that is affecting other organs and lead to multi-organ function disorder, okay, where it starts shutting down. So it occurs commonly between the ages of 10 and 30 years of age, okay? The appendix fills with food or the stool or so, and it empties regularly, but because it can't empty out efficiently, sometimes there are little remnants of food or the stool that is in the small lumen, and when that occurs, eventually it gives an obstruction or infection settle down into that area, and from there, that's where it causes the inflammation. The appendix gets inflamed, and then from there on, if it continues to stay inflamed and there is no treatment that occurs, then it has the probability of it perforating because it's so inflamed, right? It's almost as if when you stub your toe or so and it's like red around, or those cartoons where they stub their toe or their head and it's like throbbing, right? And you can think of it being inflamed to the point where it's throbbing, and once it keeps, staying inflamed and it's throbbing, eventually it's going to burst, okay? You can think of it in that concept if that helps you to understand exactly what's going on with the appendix, all right? So that's exactly what's happening, and they're more prone to obstruction and infection, okay? And ultimately, once it bursts, you are at risk for peritonitis and sepsis, right? Because all of that GI content, the stool, right, is not sterile. And once that's perforated, it goes into areas of the body that are sterile, right? And it's able to leak into the bloodstream and different cavities of the body that are sterile, okay? So the biggest thing here is sepsis and perforation that can occur with a ruptured appendix because of the inflammation. So if you want more information about the patho or more detailed patho, please check the description box below. All the information that you need will be provided in there as well. All right, so now we have the clinical manifestations, also known as your signs and symptoms, also known as your nursing assessment for appendicitis. So with appendicitis, the main thing is going to be pain, pain, and pain. So you want to make sure that you're paying attention to your patient, okay? So you're going to have pain in the periumbilical area that descends to the right lower quad. So the main famous thing right here, I'm just going to put a star next to it, is going to be the right lower quad is where you're going to feel the pain. So if you see the patient is clenching onto this area, or they're complaining about right lower quad pain, most of the time automatically start thinking about maybe the appendix, okay? Because the appendix is on this side. Also, they may have abdominal pain that is most intense at McBury's point, which McBury's point is also on the right side. It's right near the cecum area, all right? And they will complain of pain in that area, which is the most intense pain, okay? Then you have rebound tenderness and abdominal rigidity, okay? Then you have a low-grade fever. They may have elevated white blood cells, which is WBC, right? Anorexia, nausea, and vomiting. And with anorexia, we're not talking about your typical, people who are not eating because they want to stay skinny, but anorexia meaning as far as poor appetite, okay? Also here you have the client may be on a sideline position, right? And they may have abdominal guarding. And what they mean by abdominal guarding is pretty much you're guarding your abdomen. So most of the time when people are in pain, they kind of clench, turn to one side, and hold their abdomen, right? Or hold wherever areas they're feeling the pain. So when you see a patient do that, you want to make sure that you're paying attention to those signs and symptoms of pain, all right? Because you're not always going to get a person who's going to state, hey, I'm in pain. Whether it could be culturally, I know Asian descent, they try not to complain too much about pain. You'll barely even know that they're in pain unless you can literally pay attention and see the different gestures that they're doing, so that way you can ask them and say, hey, are you in pain? Because they won't say it. Some people think that it's shameful. Some people think that pain is a good thing, because it lets you know that you're still living, that you're still breathing. Some people look at it as a sign of weakness, right? So whatever background they're from, whatever cultural beliefs that they have about pain, so they may not go ahead and tell you, hey, I'm in pain and I need something. So it's up to us to pay attention to those body cues to see exactly, hey, this patient's in pain. And if they are, you ask them and just say, hey, it looks like you're in pain. Are you in any pain? Are you comfortable? Is there anything that I can do? It's okay if you get, pain medication. You just explain to them, what's going on. And from there, that can help to alleviate some of their pain, because now they can get medication, okay? So just be careful of that. Also, they may have constipation or diarrhea. And again, if they have constipation, most people will say, oh, just go ahead and give a laxative so they can kind of go to the bathroom. If they have the right lower quadrant pain is very intense, and you suspect them of having appendicitis, you do not want to give laxatives, because laxative can cause the perforation. And you may say, how is that, right? Well, if I have the area that's inflamed here, I want my whole GI tract, at least the lower part of my GI tract, to be resting, because any other irritation is just going to cause a probability of more inflammation to occur in that area. So if I'm giving a laxative, the laxative is just going to move my bowels. And when those bowels are being moved and more stool gets shoved into the appendix, or more irritation happens in that area, it just causes more of that friction to occur and eventually perforate, okay? So you want to pay attention to that. Also, these are different areas where they can feel pain. So it's not just always in the the right lower quad. Of course, that is the most famous answer, is the right lower quad. But it may be dependent on where exactly the appendix is laying or near what position, okay? So if you may feel, the patient may say, I feel pain in my lumbar area, right? This area here, maybe it's on this side, right? But they feel pain in that area. It could be that the appendix is curled behind the cecum, okay? And the cecum is just pretty much the entering part, the first beginning part of the large intestines, right? So right after it leaves the small intestine, there's the cecum area, and then you go up the ascending colon, transverse, descending, and then finally the sigmoid. So the cecum is just pretty much that first entry part from the small intestines to the large intestine, okay? So we also have pain on defecation. Defecation just means to poop, right? To go to the bathroom, to do number 2. So when the patient has pain on defecation, it can be that the appendix is on the rectum or near the rectum area, okay? So it's inflamed, wherever it's twisted or however the anatomy is, it's pressing on the rectum, which makes you feel pain when you have to go to the bathroom, okay? And then last but not least, you have pain on urination. And pain on urination, again, it could be that the tip of the appendix is near the bladder or the ureters of the bladder, okay? So again, the pain is going to be dependent on where exactly the appendix is resting, okay? But for the most typical answer, it's going to be on the right lower quad, all right? And you have Rosen's sign, which Rosen's sign is pretty much when you palpate the left lower quad, right? And you feel the pain on the right lower quad, okay? That's a positive sign to let someone know that, hey, this person may be experiencing appendicitis. So again, that's when you palpate the left lower quad and you're feeling the pain on the right lower quad, all right? And you may say, oh, that sounds like rebound tenderness. No, rebound tenderness is I palpate here, right? Rebound, I press and a rebound of pain in that area, okay? Rosen's sign is I palpate the left, I'm feeling it on the right, all right? So just so you guys can know the difference between the two, palpate left. So on the right, rebound tenderness, I palpate that area, I lift up, I get a rebound of pain. So again, the complication, mainly perforation. So you have perforation of the appendix, right, which causes peritonitis, which occurs within 24 hours of the onset of the abdominal pain, okay, or whichever pain, whether it's the lumbar pain, pain defecation, whatever pain the patient may be exhibiting, 24 hours from the time that has started, okay, that peritonitis can occur. All right, abscess formation, right, and abscess formation is pretty much a collection of purulent material in that area. It's almost like a sac-like, and there's fluids and different material that just kind of just collect over time and just stays there until finally, eventually, the abscess formation can probably start pushing and bulging on different parts of the organs. Okay, you have portal pylophlebitis, which is pretty much a septic thrombus of the portal vein caused by vegetative emboli that arises from septic intestines, okay? So this is another complication that can occur, all right? Fever from anything of 37.7 Celsius, which is pretty much 100 degrees Fahrenheit, or anything higher than that, okay? So just expect to see a fever. And then here are some signs and symptoms of peritonitis. So eventually this is what you're trying to prevent. So how do you know if the person is in peritonitis, right? So these are your signs. So they may have guarding of the abdomen, right? Increased temperature or chills, which we saw that here. All right. Progressive abdominal distension and abdominal pain right? And then they're going to be restless. And then that makes sense, right? Because if you're in pain, how can you sleep? So you're going to be restless, okay? And then you will have tachycardia and tachypnea. Most of the time, when you're in pain, your heart rate tends to go up. Your blood pressure also tends to go up. And then tachypnea, because, it hurts, so you're not taking deep breaths. You may be taking shallow breaths, right? And you may need more at a time. So it all depends on the patient, but these are your signs to let you know that this patient is exhibiting signs of peritonitis, all right? So our main thing here, you can sum up everything of complication, is peritonitis, right? Perforation is going to cause peritonitis, is going to cause sepsis. So if you can remember that, you're good to go. Diagnostic testing. So with the diagnostic testing, you're going to look to see physical examination, right? How the patient present themselves, how they're acting, what things that they're doing that may put you at concern that this patient may be exhibiting signs of appendicitis, okay? Your labs. One in particular is your CBC, which CBC stands for complete blood count. And within that, you have your white blood cells that you're going to be paying more attention to. And you're going to see an increase in white blood cells, in particular, the increase in neutrophils. Remember, there's 5 different types of your white blood cells, and neutrophils is one of them. So these are what you're going to see in acute settings, right? You have abdominal X-ray that you can do, an ultrasound. You can also do a CT scan, and the CT scan may reveal a left lower quad density or a localized distension of the bowels, all right? So then you have a pregnancy test. Of course, women will be the only ones to do this, all right, to rule out an ectopic pregnancy or before they have to do the X-ray. So anytime you have to do an X-ray or so, women who are in childbearing age who can bear kids, they're asked to do urine test, pregnancy test, right, to see if she's pregnant, because again, you don't want to put the baby at risk going into the X-ray machine. Okay, so they'll find all the other testing that they will have to do to figure out exactly what's going on. All right, and in case they do have to do it, right, you have to think of it: the life of the mother or the unborn fetus. Okay, so that's one of the things that they're going to do. And an ectopic pregnancy is pretty much anywhere besides the uterus. So that means that the embryo was not implanted in the uterus, maybe in the fallopian tubes or wherever else, but definitely not in the uterus. Okay, so that is going to cause a lot of pain. So and it can cause pain in that area, especially if it's coming down the right fallopian tube, right, ovarian tube or so. So you want to make sure that it's not one of those and you're treating the wrong thing. So they'll do a lot of testing just to kind of rule out, other things that can contribute to those same signs and symptoms, okay? And then you also have a diagnostic laparoscopy to rule out an acute appendicitis in equivocal cases. So like I said before, you do different things to check to see what may what other things could it be, right? Because it could be diverticulitis, right? And it happens to be on the right side. Or it could be Crohn's disease. Or it can be other different things, not just only appendicitis. So they'll rule out to check to see, is it really appendicitis or is it something else that are exhibiting the same signs and symptoms of appendicitis? Okay? So now we're getting closer to what are we going to do for a patient who has appendicitis, okay? So with that said, if they already have appendicitis, most of the time they're just going to go ahead and remove it because it's shown that they don't really know what the appendix function is for. With it being taken out and removed, it doesn't cause any difference to the GI tract. So most of the time if a patient is exhibiting signs of appendicitis, they're just going to go ahead and do an appendectomy. And again, when you see the word ectomy, anything ectomy means the removal of. So sometimes you may not know what a procedure is about, but just because you see certain terms, certain keywords that can kind of let you know exactly it's a removal of something, right? And you have appendectomy, so removal of the appendix, all right? So gastrectomy, right? Gastro is stomach, ectomy, so again, the removal of stomach. So that's just a heads up for those of you guys who, look at these procedures and you're like, what is going on? All right, that is a hint so that way you guys can know anything ectomy means removal of. So it's a surgical removal of the appendix, right? So this is the preoperative procedures that we need to prepare the patient for surgery for, right? So we want to maintain NPO status. NPO pretty much means nothing by mouth. So they're not going to have anything by mouth. And again, we do this for surgery, to prep them for surgery because you want them to go on an empty stomach because there are already complications in surgery as it is. And the last thing you need is to be on a full stomach in the area that you're doing the procedure, and you can cause aspiration, right? And you don't want aspiration because that's the choking of fluids or fluids going down into the lungs, and that can cause aspiration pneumonia and can cause different things to occur that's going to make the surgery worse, okay? So you want to make sure that they go on an empty stomach, so nothing by mouth. Also, you want to administer IV fluids, electrolyte therapy, or antibiotics to prevent either dehydration, sepsis, or to give them the electrolytes, right, that they need because they have a loss of electrolytes or they have an imbalance of the electrolytes. So depending on what the doctor's orders, you're going to follow that, but definitely they're probably going to have some type of maintenance fluid since they're not able to get anything by mouth, right? Also, you want to monitor for changes in pain level. So you want to know if it's getting from bad to worse, right? So that will also let you know, say, hey, our time is running short, the patient is in pain, so that way sometimes they may have to do an emergency surgery and, depending on how bad or severity the pain is, because it lets you know exactly, hey, it's perforating, sooner than later. Also, you want to monitor for signs of rupture of the appendix and peritonitis. So you may say, what are those signs? Remember, we just discussed them. So if you didn't remember, just go ahead and replay this video so that way you can know the signs of rupture and peritonitis, okay? So remember, this is our biggest complication that we're trying to prevent. So you want to make sure that you're monitoring these patients so that way if something was to happen, you need to call the doctor right away so we can do emergency surgery, all right? Also, you want to position the client in a right sideline position or a low semi-fowler's position, just for comfort, right? Just doing that or just position can just help alleviate some of that pain. So again, you already know semi-fowler is halfway up, right? And you have full fowlers is 45, semi-fowlers is around 30 degrees, all right? Or maybe sometimes 20, but mainly 30 to 45 degrees is fowlers, okay? And then you want to either put them in the right sideline position, or this is my right, the right sideline position, okay, to just provide comfort. Also, you want to monitor the bowel sounds, right? You want to be making sure that you're hearing something. You don't want to hear absolutely nothing because then we have a paralytic ileus. That means the GI tract is, completely done, and that means either the perforation has already occurred or starting, and we're at a life-threatening condition, okay? So you want to make sure that you're at least hearing something. It can be very low because they're not eating anything, but to hear absolutely nothing, you want to make sure that you're letting the doctor know, hey, I don't hear a bowel sound. And you've listened to all 4 quadrants, and you'll listen to the first. You always start on the right side, the right lower, and then work your way up to the right upper, the left upper, and then left lower quad. And you'll listen here for 5 whole minutes if you do not hear anything. All right, so if you hear absent bowel sounds, you will listen to 5 whole minutes in that one quadrant. And if you do hear something, then you move on. And if you don't hear anything, you wait for that 5 minutes to see if you hear something, okay? Also, you want to avoid, and I put it in red so that way it can pop out at you, right? Avoid application of heat. I know sometimes, you know, we're cramping or we have abdominal pain, we like to use heat because heat helps to alleviate. I know I do. I like to use heat pads and things like that. But when it comes to a patient who is having appendicitis or suspected appendicitis, you do not want to give heat to the abdominal area. Why? Because it is going to cause the perforation. So heat can cause a rupture. And once that rupture occurs, we have peritonitis, which is a life-threatening condition. So let me just highlight it. Okay? Life-threatening condition with heat, so we do not want heat. All right? It's just only going to speed up that process a lot more. So what do we want to do? We want to apply ice packs to the abdomen. 20 to 30 minutes or so, you want to put it to the abdomen, and you'll probably do it every 1 hour as ordered. So you see Q1H. Q1H means every 1 hour. All right? I don't know where they get the Q4 for every, but that's just how they do it within the hospital setting. So anytime you see orders and you see Q1 H or Q2H, whatever it is, that means every 2 hours, every however many hours. And if you see Q, the number, and then MIN, that means minutes. Okay, so it may be, you know, Q 20 minutes or so. So whatever it is, just know your abbreviations. I think they go over it in fundamentals. So if you guys are rusty on your abbreviations, make sure you go back and you review it, so that way when you see different things, you know exactly what that means. All right. And then last but not least, avoid laxatives and enemas. So again, like I was saying earlier, you want to avoid laxative because the patient may experience constipation rather than diarrhea. And you may say, I feel so uncomfortable and I just want to go, so I take a laxative, right? And milk, laxatives can be anything as far as like milk of magnesia, right? Bulk forming stool, anything that kind of help you go to the bathroom, all right? Those little citric magnesium bottles, it's like in a clear bottle, almost like a soda bottle or so. And you drink that whole thing, almost like a soda consistency or so. You'll drink that, and that kind of helps you go to the bathroom. So any type of those laxatives you want to avoid, because again, the inflammation is in the lower part of the GI tract. I don't want my GI tract to be moving and functioning, you know, because I want this area to rest, because otherwise it's going to cause the inflammation to occur or cause more inflammation that is eventually going to lead to peritonitis. All right, so no laxatives, no enemas. You don't want anything going up there because it's going to stimulate the GI tract as well. Think about it like this, right? You're injured, you're hurt. Do you want to play outside, or do you go to a hospital, or do you go at home and you rest, right? You go at home and you rest. You don't play outside, right? So if you have a gunshot wound or anything like that, whether it's in the leg, you don't continue to irritate that same function, that same muscle, that same organ. You want it to rest, all right? So think of it in that sense. So now we're going to talk about post-operative procedure. So after they have done the surgery already, right, these are the things that you're going to do as a nurse to maintain this patient, okay? So you're going to monitor temperature for signs of infection. So again, we're supposed to be doing that anyway for your vital signs, right? Every 4 hours or so. If the patient is in the ICU, of course, you're going to do it every 4 hours. But your vital signs are going to be more frequent, so maybe every 30 minutes, every hour or so, okay? You also want to assess incisions for signs of infection, such as redness, swelling, right, or pain. So all those are indicators of letting you know that, hey, maybe there's an infection. Also, too, the type of drainage that comes out. If you see like a yellowish type of drainage or so, that can also let you know that that's infection, because that's like the pus, mucus type of drainage that's coming out, okay? So you want to pay attention to that. You also want to maintain NPO status until bowel function has returned. So again, you never put a patient on a diet until you hear bowel sounds, right? So same thing, main thing that you worry about when the patient comes out of the surgery, especially if you're a PACU nurse, is that you want to make sure that, one, they have urine function, right? So most of the time they won't leave that PACU or they won't leave home until the person has urinated, okay? Because if they have not urinated, then they may have to go back to surgery because something is not right, okay? Also, too, is bowel function. So you're not going to get anything to eat unless I hear bowel function, because bowel functions lets me know and let all the healthcare professionals know is that, hey, this patient GI tract is working, right? So even if you haven't eaten anything, there should still be some type of sound, some type of bowel sound you should hear. So again, that's going to be indicated, let you know that, hey, this patient is ready to eat, because I know once the food goes down, that the stomach is going to be there to work on the food, to digest it and do what it has to do. If I don't hear anything, right, and I was to give a patient some food, it's just going to sit there, especially if the stomach is not working, right? It's going to sit there, it's going to rot, and it's going to cause more problems and more damage than you want, okay? So you want to make sure that you don't have a diet until you hear those bowel sounds, okay? Also, you want to advance the diet gradually as tolerated when the bowel sounds do return, okay? So most of the time they'll be on a diet advanced as tolerated, okay? Also, if there's a rupture in the appendix, if it does occur, right, you want to expect the Penrose drain to be inserted, and the incision can now heal from the inside out. All right, so the Penrose drainage is pretty much like this rubber drainage that comes out of the incision, and sometimes it has like a safety pin on it or so, but it's not really connected to a bag. All right, so it's almost like a JP drain, but has its difference because it doesn't have a bulb syringe, a bulb connected to where you can put compression pressure on it, or suction, right? So it's just kind of a drain that kind of just sticks out and it just drains. So you will have the dressing with the gauze and everything, and it will just drain on the gauze or so, and you will just change the dressing however so often you need to change it, because it's been soiled or per the doctor's orders, okay? So you want to expect the drainage from the Penrose drain to maybe perfuse for like about 12 hours or so, all right? Also, you want to position the patient, so right side lying or semi-fowlers, okay? And that kind of helps to facilitate the draining of the Penrose drain, all right? Another thing is you want to change the dressing per doctor's orders. Most of the time, you don't change the dressing until post-op day number 2. So if it's post-op day number 2, then you go ahead and change that dressing. But remember, we don't change the initial dressing. Nurses are not allowed or not supposed to change the initial dressing. It's supposed to be the physician, the doctor or the surgeon who did the procedure. He will come back because, again, he needs to see how the wound looks, how it's healing, how it's progressing. Is it getting any better? Is it getting any worse? Is there any sign of infection? So normally, typically, he's supposed to be, or she is supposed to be the one who does the first initial dressing change. After that, then it's the nurses. But again, when you go into the hospital setting, you're going to see something completely different, but you always just follow what the doctor's order. So sometimes the doctor may say, hey, I want you to change the initial dressing, okay? Or the patient is not there, or wound care is on consult, right? So you will see these things occurring. Not saying that it's right, but you may see those things occurring, all right? But for your NCLEX purposes and for your classes purposes, we do not change the initial dressing. The doctors is supposed to change the initial dressing, all right? And you will follow the dressing orders. He may say clean with normal saline, or clean with sterile water, or pack with gauze, or put an ABD band. Whatever he wants, he will have to put it in his orders and how often he wants the dressing changes, okay? Or he may say put Silverdene, or put whatever the order is, all right? Also here, you want to perform wound irrigation if it is ordered. So again, if it's not ordered, don't worry about it, okay? And you also want to maintain NG suction. So these patients may come back with an NG tube, right? And it may be attached to low intermittent suction, and it's pulling all of the gastric content or whatever extra material that's not supposed to be, or just to kind of help facilitate prevention of abdominal distension, right? You want to get some of those fluids off, or to help prevent aspiration, okay? And you also want to make sure that the NG is patent, because it does get clogged from time to time, especially if the patient is on feeds, right? Let's say they do have bowels and they're on feeds or something like that, or it may not even be this patient, just NG tubes in general. It gets clogged from time to time, and you're like, man, I can't flush it in, nothing is going in. One trick, and I put it in blue, to maintain patency, they can do it with soda. So sometimes the hospitals, they will have like Diet Pepsi or Coca-Cola or ginger ale. At my hospital, we have ginger ale. We don't have any other thing but the ginger ale. So you can take some of the ginger ale, just a little bit, and what you'll do is you'll put it in the NG tube, and you'll leave it there for a little bit, and the acid from the acid from the soda or so will kind of help to push whatever is clotted in there or blocking, push it through, and eventually you have a clear NG tube line again. All right, so that's a trick. Also, you can use warm water. All right, that also helps as well. So, is it harmful to the patient? No, it's not. It's almost as if you were to drink soda yourself, right? And you're only using a little bit just to only clear the line. Okay, so you'll see nurses in the hospital. That's what they do to help keep the NG tube patent. They'll leave it there sitting for a while, wait about 10 minutes or so, and then take warm water or regular water and then flush it so that way it continues to flow. Okay, and then you may want to administer antibiotics and pain medication per, of course, doctor's orders. So, of course, a patient like this is going to come back on some type of pain medication, or if they don't have one ordered, you may have to call the doctor to see if they can get one ordered. Okay, and administer antibiotics prophylactically, just so that way, because remember, any incision is a risk of infection. And, when you're closing that person back up, you never know the risk of infection. So for prevention purposes, you may see the patient on antibiotic therapy just to prevent, right? Or even to treat if they do have an infection, right? If you caught it too late and the doctor was able to get in there, but it perforated while it was in there, right? They may put them on antibiotics, all right? So just expect to see those things, and these are what you're going to do post-operatively, okay? So again, I just want to thank you for watching. Remember, if you haven't subscribed, what are you waiting for? Don't hesitate. Go ahead and subscribe. If you like this video, give it a thumbs up. Share it with a friend. If you have any comments, please don't be shy to comment in the comment sections below. And again, remember, any extra information that you may want to see or know about may already be in the description box. So take a look at the description box when you get a chance. And again, thank you for watching and coming on this journey.